Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Good afternoon. My name is Cheryl Brunelle. I'm so happy to be here today. I'm thankful to LE&RN for the invitation to come and speak about our work on the COVID-19 vaccine and breast cancer-related lymphedema. I am a physical therapist. I'm a certified lymphedema therapist. I've been treating patients with lymphedema for about 22 years now. I'm also the Associate Director of the Lymphatic Research Program at Mass General Hospital. So today I'll be speaking for probably about 40 to 45 minutes. I'd like to leave time to see if I can answer your questions at the end of this talk. If you'd put those in the Q&A, I'd appreciate it, and we'll go through those at the end. I'd like to thank the sponsors of this symposium series through LE&RN. I'd be remiss if I didn't say that this is the work of our entire team. And we have 3 wonderful clinical research coordinators on our team. I would like to give a special thank you to Swell, who's been instrumental in this study since the day we decided to conduct it, and to my co-director, Dr. Alphonse Tegian from Radiation Oncology. These are my disclosures. I would also like to acknowledge those who fund our program and sustain it from year to year so we can complete projects like this one. So why do we screen for lymphedema? Well, we used to see patients more so like the woman in the picture on the right with moderate to severe lymphedema, and with that comes moderate to severe symptoms. Her tissues have changed. This is later stage lymphedema, and it is much harder to treat. When we screen for lymphedema, we can see patients more like the woman in the picture on the on the left, who has less swelling in her arm and hopefully less symptoms. This is much easier to treat and more reversible at that point. We can only diagnose lymphedema early and treat it that early if we're screening for it. We know there are many benefits to screening. This allows for accurate diagnosis, which I will talk about more in a moment. It allows for better outcomes because we know that early lymphedema is reversible. Better quality of life. We can control treatment burden for patients. We can have them in the clinic less often for less duration. We can control their symptoms and maintain their function when we treat early through screening. And screening simply costs a lot less than a more historical impairment-based model. I include some references here. So when we screen at Mass General Hospital in Boston, we incorporate data from several different areas into our screening program and into the decision as to whether or not to diagnose a participant or patient with lymphedema. So we ask them about symptoms, specifically those that we know might be indicative of developing swelling. We measure their arm volume over time to look for small changes. We clinically examine them, and central to this process is really the patient vigilance between screening visits. We want the patient to understand what her risk factors are and when to call us with changes or subtle signs or symptoms of swelling. We use a pyrometer that is a machine shown in the picture here. It is a machine that calculates limb volume. So the large square frame is run up and down the patient's arm. We measure both arms, and the machine calculates limb volume in milliliters. So we take measurements of both arms at each screening visit, and we enter the average arm volume of each arm into this formula. This is called the relative arm volume change formula, and it's a formula that our team developed years ago. I include the reference here for you. And we talk to patients about their relative arm volume change from their pre-op baseline. So this formula includes the volume both at the preoperative baseline and then the most recent measurement. And we'll say to patients, your RVC is 5%, 10%. And generally we refer for certified lymphedema therapist treatment at an RVC of 10%. And more recently, we've been moving to considering referral for participants or patients who have low volume swelling changes, but might be complaining of symptoms, or who are at higher risk of lymphedema. So screening starts at breast cancer diagnosis. We published data from 1,028 women who were measured before breast cancer surgery and were followed over time. And we found that 28.3% of them had one arm that was 5% larger or more than the other arm, and 2.9% had one arm at least 10% larger than the other. So if we're diagnosing based on a 5% difference or a 10% difference, then that will be inherently erroneous because we don't know if the patient had an arm asymmetry before surgery. And we found that with this data, we found a 40 to 50% misdiagnosis rate when a preoperative measurement wasn't included. So we really strive to get these measurements preoperatively in our screening program. So this is an illustration of our screening program. So we see patients before surgery. We just take an arm measurement at that time. We see them after surgery and at each oncology follow-up visit for up to 5 years if we can. We know that most patients who develop lymphedema do so within that time period, so we'd like to capture that. After surgery, we know what the patient's risk factors are for lymphedema. So we can talk to her about what her risk factors are, what symptoms to look for, and when we would like her to reach out to us if any of those changes happen. We measure arm volume, we give symptoms questionnaires, and we continue this patient education throughout the screening. We have screened over 6,000 women to date since the screening program started in 2005, with a median follow-up time of 31.6 months post-surgery. Traditionally, we receive referrals in 3 different ways to our lymphedema therapists, either through the lymphedema screening program when one of our research coordinators measures an increased arm volume, or the patient may tell them that they're having symptoms. We get patient-initiated referrals as well, where patients reach out and say, I'm having a little bit of arm swelling, something feels different. We have them come in for measurement and for evaluation. We also receive referrals from physicians and nurse practitioners in the oncology clinic as they see their patients. This worked very well before COVID, and this graph depicts the number of measurements that we did per year over 2017, 2018, and 2019. The darker blue is new baseline measurements, so those preoperative measurements. You can see that goes up each year. And the lighter blue is follow-up measurements. And you can see that that goes up each year, was stable between 2018 and 2019. Well, then in March of 2020, COVID-19 hit. And as we know, everything changed. So our lymphedema screening program unfortunately had to close from March 16th to June 19th of 2020. So this safety net for patients, this screening program was gone for those months. So we were hopeful that patients understood when to reach out, when to call. However, during this time, there was a lot going on at MGH, and patients certainly did not want to be coming into MGH if they didn't need to, and they were scared to do so, understandably, because of the pandemic. So patients were not getting screened, and for the most part, we weren't seeing patients at MGH either. So we saw our screening numbers go down exponentially in 2020, and we can see that here. In 2021, we started to recover, and this is the number of measurements over each year. In 2021, we started to recover in terms of our screening measurements. We actually saw more new baseline patients preoperatively than we did in 2019. I think that was because so many people missed mammograms and unfortunately had new breast cancer diagnoses in 2021. But the follow-up measurements did not recover during that year. And you can see this on this graph. This depicts the number of measurements over calendar months throughout 2019, 2020, and 2021. So in 2019, you can see this nice line where we had a relatively stable number of measurements per month. In 2020, you can see this line literally free fall come March, and we didn't recover through that year. In 2021, we recovered as the year went on, and then we had this little dip at the end, probably due to Omicron. So, through this time, we were really trying to get care to patients as best we could, and patients were really struggling with access to care. There just wasn't access to care at that point. There were all of us behind the scenes trying to pivot to do virtual visits, which is worked well for some patients and did not work well for other patients. We were trying to make post office runs and porch drop-offs as best we can to get compression to patients. And behind the scenes, some lymphedema therapists, as in these references, were really doing a good job of reflecting on lymphedema management during COVID and trying to put together guidelines. LE&RN very early in the pandemic published on the right here some guidelines for the lymphatic disease community regarding the risk to those patients of COVID-19, highlighting that they were not at a higher risk with COVID-19 for the most part. And Kathy Shalou from the Beth Israel Hospital also did a nice symposium about managing lymphedema under stay-at-home orders, which I found to be really helpful for patients. And finally, the group in Wales under Dr. Melanie Thomas did a wonderful job of reflecting on their experiences during COVID and putting together guidelines for managing lymphedema remotely. And that's the last reference here, which I find very helpful if in the event we run into this in the future. So we wanted to look at data reflecting on our practice during COVID. We measured 490 patients the year before COVID in 2019. And of that 490 patients, 100 had low volume swelling or swelling between 5 and 10% that year. And we know that that's a risk factor for progressive lymphedema. We wanted to see if those patients were measured after COVID hit and kind of where are they now. Well, of those 100 patients, 64 patients were not measured after March of 2020. So we're not sure. We're hopeful that they are fine and that they understand when they should reach out and that they know we're here if they need us. 23 patients measured either under 5%, so no edema, doing well, or 5 to 10% stable after March of 2020. So that's good. They've continued with screening. And 13 patients measured with over 10% after March of 2020. And so that would be lymphedema. And luckily of that 13 patients, we saw 9 patients and 6 of them recovered. They were seen at MGH and they recovered to less than 5%. 3 other patients were seen outside. We don't have updated measurements for them. And 4 patients, we repeatedly tried to get a hold of to get in for either virtual care or in-person care, and we're not able to do that. So COVID had a significant impact on our ability to continue to screen patients and to care for patients. So flash forward to January 2021, the COVID vaccine becomes available. We started to vaccinate our staff at MGH the first week of January, and almost immediately we started to get phone calls and emails. This was an email from one of the oncologists to our lymphedema research team, highlighting that there had been multiple reports of lymph node enlargement after COVID vaccination. One of the staff was examined due to this, and there was definitely impressive lymph node swelling. So during that following week, we were a bit blindsided by this, to be honest, and we wanted to try to put together a response to this to figure out what should we be telling patients about the vaccine. They were starting to call, they were concerned and worried. We were starting to see reports in the literature of this side effect. This is one in the journal Clinical Imaging, published a week later on January 18th. And then on January 19th, we were able to put together an email to the Breast Cancer Center staff. It was important to us that we were all, as a multidisciplinary group, giving the same messages to patients. We highlighted the reports of lymph node swelling. We highlighted that screening was available to patients at any time, that we were going to submit an application at MGH to study patient experiences with the vaccine. And we included our patient recommendations that we had discussed with the Breast Cancer Center leadership at that point. Other facilities were and organizations were certainly working on this behind the scenes too. The LE&RN put this update on their website, including the THI as an alternative vaccination site that was listed by the CDC. They included links to the CDC standing orders documents and the CDC website. So at this point, people were understanding that because of lymph node swelling, the THI was an alternative site for vaccination. We also decided that this was a global problem. We really wanted to reach out to the national and international lymphedema organizations as best we could to see what else was happening in this world. And we reached out to LE&RN, to the ILF, to the American Lymphedema Framework Project, the NLN, and the ISL, talking about this side effect, knowing that there's very limited information. This was a worrisome side effect for patients. Our previous research does not apply, and some of you may be aware of our previous research in which we found that needle sticks on the side of risk of lymphedema was not associated with increased arm volume. That was not research on an mRNA vaccine, so we did not feel like that applied. We were submitting to study this and wanted to know if other research was going on. And our approach was conservative, and we shared our recommendations on that email. We received quite a number of gracious responses back. Certainly LE&RN responded to us with this as well. This was a very nice response just a few days later. We're still in February of 2021. So within about 4 weeks or 5 weeks, when lymph node swelling became an issue with the COVID-19 vaccine, they got this information out and disseminated it widely within days. They did just an amazing job with this and really were supportive of a collaborative approach and wanted to be informed of research as well. It took us until the end of February to get the information out to the Mass General community in a unified way. Obviously, any communication during COVID to a vast number of patients needed to be approved through MGH. So we did that towards the end of that month. We were able to get this up on our website. It's still there. Our recommendations for the vaccine for patients who have lymphedema or were at risk of lymphedema were to receive the vaccine in the opposite arm or in the leg. And if lymph nodes have been removed on both sides, to receive the vaccine in the leg, or if not possible, in the arm with the fewest lymph nodes removed. We also linked to the CDC documents and translated this into 5 different languages for patients. So trying to get this information out, patients were starting to understand that the leg was an option. They were starting to get that education and that information and receive that. However, when they went to go get the vaccine and try to receive the vaccine in the leg, they just couldn't. So this patient wrote, "It has been a nightmare getting the vaccine anywhere other than the arm." She even called Moderna and was told that the emergency use authorization did not apply to the leg. She said, "This is outrageous. I can't possibly be the only patient with bilateral lymphedema." And she aptly noted that although patients are advised to ask their doctor, the physicians did not have the information for them. So this was an incredibly worrisome time. We continued to try to get this information out. This is a newsletter through MGH in April regarding lymph node swelling and the COVID vaccine to raise awareness. And then at the end of April, there was an article in the New York Times entitled, "Do I have to get the COVID vaccine in my arm?" And Dr. Tagan and I were interviewed for this article. And when I looked back to take the screenshot for this presentation, I was reading through the comments, and 2 of them really struck me. One of them said, "I'm starting to feel like I'd have a better chance of winning the lottery. It should not be this hard to get something that's approved by the CDC." The other said, "This has taken countless calls, time waiting on hold, a lack of understanding of why this is important for my body. It's recommended by professionals in an acceptable location, but is denied by local clinics." And we were hearing this over and over again, that patients could not get the vaccine in their leg. So just backing up a little bit, why are mRNA vaccines injected into the arm? Well, the deltoid muscle, or the arm muscle at the top of the arm, is a muscle that's large enough for this and safe enough for this, and it's accessible. So we're receiving the vaccine in a public area. Usually the arm makes the most sense. This muscle has a good blood supply to disperse the vaccine, and that helps to minimize the local side effects of the vaccine. The muscle also contains immune cells, which pick up the antigens when they're injected, brings them to the lymph nodes. Why do lymph nodes swell after COVID-19 vaccines? I will note that lymph nodes also swell after other vaccines, such as the flu vaccine. However, the immune response with the COVID vaccine is greater, so we are seeing this side effect more so in this population. Lymph nodes contain white blood cells. They're part of our immune system. The lymphatic system is the largest part of our immune system. These blood cells recognize the antigen and they start to fight and create antibodies. All of this cellular activity can lead to inflammation and swelling in the lymph node. And the lymph nodes most likely to swell are those closest to the injection site. So in this case, either the supraclavicular or on top of the clavicle or collarbone lymph nodes, or the axillary or under the arm, the lymph nodes under the arm. So they are the most likely to swell. And this is a sign that the immune system is acting as it should when an injection is given. The problem is that lymph node swelling is a concerning symptom, especially to patients who've had a diagnosis of cancer. Our previous data does not apply, so we are left with what should we tell patients based on what we know. We know that our patients who've been treated for breast cancer have had lymph nodes removed. They've had a trauma to the lymphatic system in that area. We were wondering if they would experience more side effects than the general population. We also wondered what the longer term impact was of the vaccine for patients at risk for or with lymphedema. So we conducted the LymphVAX study. The purpose of this study was to elicit patient experiences and side effects associated with the COVID-19 vaccine after breast cancer surgery. Our study population included females of 18 years of age or more with a history of breast cancer and at least one barometer measurement. We collected data from April 2021 to February 2022. In fact, we're still collecting data, but this was the cutoff for this presentation. This was an electronic survey sent to patients through their patient gateway, which is a secure communication between MGH and patients. So we sent patients the survey in April 2021, July 2021, and then a booster survey was sent in October of 2021. We asked patients about their experiences with dose 1, with dose 2, and then with the booster dose. So they could answer one or all of those surveys. We asked them which vaccine they received, which doses they had received, and if they declined, what their reasons were for declining the vaccine. We wanted to understand that as well. We asked them about the location on the body where the vaccine was received, whether or not they'd received any advice or education about this, if so, from whom. We asked about the choice of location on the body and the reasons affecting that choice. We analyzed data from several side effects. The side effects listed here in white are those listed by the CDC. And we added 3 additional side effects because we know those symptoms may be indicative of developing lymphedema. We also asked about how long these side effects lasted with each dose. Finally, we asked about lymph node swelling. Did the participant experience swelling? If so, at which lymph nodes? And how long did this last? So these are the demographics and treatment-related characteristics of our cohort. There were 616 participants who responded to the survey and are included in this data. They had an average age of 53. And in orange here, I highlight 3 factors that are known risk factors for lymphedema development. And in this cohort, 57% of patients had a body mass index of more than 25 kilograms per meter squared, which is a risk factor for lymphedema. 27.4% had undergone lymph node dissection as part of their breast cancer surgery, and 25.6% had undergone regional lymph node radiation. So when I look at those numbers, I think that's a very representative cohort from our breast cancer population at Mass General. You'll note there's some missing data here. This is simply because we haven't had time to enter this data yet. We are entering it now. So when we publish this data, we will include that, but it does not affect today's analysis. So in terms of the type of vaccine received, 38.4% received Moderna, 54.1% received Pfizer. There were 50 participants who received Johnson & Johnson. We're not presenting that data today because this is not an mRNA vaccine. The immune system responds differently, and it's not a overly well-used vaccine at this point. So 27%, only 27% received education about where on the body to receive the vaccine for dose 1. So this is not very many people who received education, and this is probably because there was difficulty disseminating this education. Those who did receive education reported that the majority reported they received that from oncology or from MGH, which makes sense. These were patients from MGH contacted by MGH. And then next was education received from the person administering the vaccine. You'll note that very few patients received information from their PCP and even less from the internet, which I was actually quite happy about. Dose 2 was almost identical, so I won't present that data as well. 90% of participants chose where on their body to receive vaccine, and I think that's fantastic for dose 1. The reasons they gave for receiving the vaccine in that location was, first of all, the side of breast cancer treatment, which is good that that was being considered. The second reason, though, was arm dominance, which was considered above the risk of lymphedema or lymphedema, which I found to be interesting. Dose 2 was almost identical. In terms of vaccine location on the body, 77.4% of participants received the vaccine on the arm opposite to breast cancer. 21.6%, however, that was 123 participants, received the vaccine on the arm on the same side as breast cancer. I found that interesting, but when we think about the reasons that patients were reporting for this decision, 82% of these participants who received the vaccine on the side of breast cancer, this was their non-dominant arm. So this was about arm dominance for this part of the population. And the same applied for dose 2, where 78% of participants receiving the vaccine on the arm on the side of breast cancer, that was their non-dominant arm. So did those who received the vaccine on the side of breast cancer for dose 1, did they switch to the other side? We thought that may be the case for dose 2 because we were educating patients and trying to get the information out at that time. 80% of participants continued to receive dose 2 on the side of breast cancer, with 20% of participants switching. Those who received the vaccine on the same side as their breast cancer, unfortunately, very, very few of them received advice about this location, with only 4% and 6% reporting that they received any education about this. And the main reason for receiving the vaccine on the side of breast cancer was arm dominance. Very few participants received the vaccine in their leg, only 8 for dose 1 and 10 for dose 2. The reasons given were they considered the side of their breast cancer treatment, risk of lymphedema or lymphedema. One participant said she had upcoming breast imaging and did not want lymph node swelling showing up on her breast imaging. And that was a whole group of researchers were putting together research on that. And there are some publications in that area. I think these numbers are so small because there was a lack of access to this vaccine on the leg. Participants were just not able to achieve getting the vaccine on their leg. So this slide depicts the studies that were done on the Moderna and Pfizer vaccines before the FDA approved them. So each of the vaccines were studied in very large randomized controlled trials on the general population. So this was not on the population with breast cancer. This was the general population aged 16 plus, either healthy or with stable chronic medical conditions. These studies are both large randomized controlled trials where participants either received the vaccine or they received a placebo. Both of these were published in the New England Journal of Medicine, and I include the references here. So Pfizer looked at 43,548 participants, Moderna 29,106 participants. They used an electronic diary for 7 days wherein participants reported side effects. And Pfizer and Moderna both asked participants specifically about several solicited side effects. So asking them, did you get pain? Did you get redness after the vaccine? Lymphadenopathy or lymph node swelling, which is the side effect we're most concerned with today, that was a solicited side effect from Moderna. So participants were specifically asked whether or not they had lymph node swelling after the vaccine. That was not a solicited side effect in the Pfizer study. So there were participants who reported it, but all they could say in that study was that there were 58 more cases in the group receiving the vaccine than in the group receiving the placebo. That lymph node swelling in the Pfizer cohort lasted a mean of 10 days. In the Moderna cohort, however, 10.24% of participants reported lymph node swelling after dose 1 and 14% after dose 2. We would expect that report in dose 2 to be a little bit higher because that immune system is primed and the antibodies are being created with the second dose. It only lasted 1 to 2 days, the lymph node swelling in the Moderna cohort. So we are going to compare our reports of lymph node swelling in our LymphVAX study today to the Moderna cohort here The other side effects we will compare to both the Pfizer and Moderna studies. So coming back to our LymphVAX data, how many participants reported side effects? Well, between 85 and 95% of participants reported side effects. And this is the percentage of participants reporting side effects, any side effects, for either dose 1 or dose 2, Moderna and Pfizer. And we put those next to the general population reports from the New England Journal of Medicine data. You can see the numbers are very similar, perhaps a little bit more for Moderna in our cohort and a little bit less in Pfizer, although we don't have statistics here, so I can't say that those numbers are statistically different. They look very similar. In terms of which side effects were reported, the top 4 side effects reported in our cohort for both Moderna and Pfizer were the same as the side effects reported for the general population. And the numbers were very similar. So these graphs depict the percentage of patients reporting the top 5 most frequently reported side effects for dose 1 and for dose 2 in LymphVAX, and then compare them to the New England Journal of Medicine data on the bottom. The numbers, again, are very similar. The side effects are very similar. The one thing I did notice, interestingly, is that in our population, participants reported far fewer headaches than in the New England Journal of Medicine data, and that was for dose 1 and dose 2 for both Moderna and Pfizer. In the Pfizer cohort, again, the most frequently reported side effects were the same. The top 4 were the same in both for the general population and in our LymphVAX study for dose 1 and 2. Again, the numbers very similar. And again, much less reports of headaches in our cohort. When we asked about lymph node swelling, we asked participants if they experienced swelling in the lymph nodes in the axilla, which is we define as the underarm or the armpit area, and define that as discomfort or noticeable when looking or touching. And we asked about whether that was in the axilla or in the supraclavicular or above the collarbone lymph nodes. So this depicts the reports of lymph node swelling in dose 1 for our participants. And 61 participants, or just about exactly 10%, reported lymph node swelling with dose 1. This is almost identical to the general population reports at 10.24% in the Moderna cohort. So we can see here that most participants who reported lymph node swelling reported axillary swelling, and most participants reported swelling on the same side as the vaccine. But there were a number of reports of lymph node swelling on the other side, especially in the axilla. 15 participants reported lymph node swelling on both sides. For dose 2, again, very similar to the New England Journal of Medicine general population cohort, 13.1% of participants reported swelling with dose 2 in the lymph nodes. Again, most of them axillary swelling, and in that axillary swelling, most of them were on the same side as the vaccine. When we looked at the participants who received the vaccine on the same side as breast cancer, really the same pattern emerged. Most of the swelling was in the axilla, and most of the swelling was on the same side as the vaccine. In dose 2, this number went up. Again, we would expect that with the increased immune response. However, these numbers are really small. How about how long the duration? What was the duration of lymph node swelling? So in our study in the Moderna, those who received Moderna reported that lymph node swelling lasted a median of a week. And for the Pfizer cohort, a median of 2 days to 1 week, or 1 week for dose 2. So when we compare that to the general population, lymph node swelling in our cohort seemed to last longer for patients who received Moderna and shorter for patients who received Pfizer. Again, these are not really high numbers, and we don't have statistics for this yet. Okay, so those who are at, those who are at higher risk of lymphedema were not more likely to report lymph node swelling. So those who are at highest risk are those who had axillary lymph node dissection, and they were not more likely to report lymph node swelling than those at lower risk of lymphedema. And this was not statistically significant. So I think that's an encouraging finding. And those who are at higher risk of lymphedema were more likely to receive the vaccine on the arm opposite to breast cancer. Again, this is encouraging that those who have a higher risk of lymphedema are more apt to receive the vaccine on the arm opposite to breast cancer. We are careful at MGH to say that those at low risk are not at no risk. So again, those with sentinel node biopsy were still more likely to receive the vaccine on the arm opposite to breast cancer than the arm on the side of breast cancer, which I think is encouraging as well. When we look at the booster dose data, we only have data for 219 patients. However, I'm comparing this to dose 2 data, and a lot of this is very encouraging. So 31.9% received advice as to where on the body to get the vaccine. So this was more than for dose 2. So I'm hopeful that more patients were receiving this information. Also, more to 95% of patients chose which side to receive the vaccine. So that's encouraging that more patients were able to make the choice as to where they wish to receive the vaccine on their body. The reasons they gave for the location of vaccine, it was also encouraging to see that less patients were reliant on their arm dominance as a reason for where they received the vaccine on the body. And a lower percentage of patients received the vaccine on the same side as breast cancer than for dose 2. The side effects, there was a higher percentage of participants who reported side effects after both the Moderna and Pfizer vaccine for the booster, which again, we may expect given the immune response increasing with each dose. In terms of lymph node swelling reported in this cohort after the booster, there was a higher percentage of patients who reported lymph node swelling anywhere, higher percent who reported on the same side as the vaccine and on the opposite side of the vaccine, which again is not surprising given the increased immune response with the booster dose. Frequently reported side effects after receiving the booster dose. Again, the top 4 most frequently reported side effects were similar in both dose 2 and in the booster dose. And the numbers were quite similar. The one thing that I did notice was different is that with the booster dose, our cohort seemed to report much more injection site soreness with the booster dose than with dose 2. Otherwise, the numbers seemed fairly similar. So in conclusion, participants treated for breast cancer had a similar side effect profile to the general population of the New England Journal of Medicine test cohort, and I think that is an encouraging outcome here. The percentage of participants reporting lymph node swelling in this cohort was not higher than the general population, even in those who received the vaccine on the same side as breast cancer. Lymph node swelling under the arm was reported more often than supraclavicular swelling or swelling above the collarbone. It was reported, lymph node swelling was reported on the opposite side of the vaccine, but at a lower percentage than on the same side of the vaccine. Reports of lymph node swelling did not differ by lymphedema risk. Those at higher risk were not more likely to report lymph node swelling. Those participants at higher risk of lymphedema, so those who had lymph node dissection, more frequently chose to get the vaccine on the arm opposite to breast cancer than those with lower risk or no nodes removed. And I will add that those at low risk or post-sentinel node biopsy were still more likely to receive the vaccine on the opposite side to breast cancer. The duration of lymph node swelling appeared slightly longer for those receiving Moderna in our cohort and shorter for those receiving Pfizer, but these numbers are very small. I don't think we should draw conclusions here, and further research is required. This study had limitations. We needed to rely on recall from participants because by the time we were able to get this study through our institutional review board at MGH, it had definitely been, I think, 3 to 4 months before we could get it through the review board. So some patients had received their doses of the vaccine and had to recall their side effects. We also relied on self-report for lymph node swelling because this was a survey sent out to patients. We did not follow up with clinical exam or imaging. We had limited data on those declining the vaccine. I'd be very interested in the choices around that. And we hope that we get more booster data as the surveys continue to come back in. So further statistical analysis is required. We plan on that, and we will publish this data. In terms of future directions, we would really like to see a universal approach and structured patient education for boosters. One very eminent researcher for lymphedema suggested that perhaps the WHO and the CDC, these groups should be communicating with them to discuss the need for patient education around this. We need to get information to providers. The physicians did not, PCPs certainly did not have this information. Patients were telling us this. We continue to recommend the opposite arm to lymph node removal or the leg. How do we help participants who still want to receive the vaccine in the leg? This is difficult to know because access to this was very difficult. We need to think more about that. But we would like to see this choice offered to participants who want it. Finally, we want to monitor long-term effects of vaccination. So we understand there will be a long-term need for boosters, and we know that the body has an increasing immune response to these boosters. So we would like to look at the cohort within our cohort. So the 61 participants who reported lymph node swelling after the vaccine, we would like to be able to monitor their arm volumes and their symptoms over time to see what the longer term outcomes are after this. There is one case report in the literature. I'm sorry, I didn't put the reference up here, but it's actually a group who reported on a patient who received the COVID vaccine and developed lymphedema in both legs. And he had lymphedema on lymphoscintigraphy and really didn't have a medical reason why. But other than that one case report, I will say we are not anecdotally seeing patients coming in with newly developed lymphedema after the COVID vaccine, but I do think we need longer term data on this. I know this is a lot of data. I'd like to thank you very much for your attention. This is a picture of the Zakim Bridge a few years back on World Lymphedema Day, and I look forward to when our lymphedema community in Boston can come back together on the other side of this pandemic. So I'd like to stop sharing my screen here, and I would like to go to the questions and answers and just spend some time trying to address some of those things, and those that I can't address, I'm happy to try to do offline. I have a couple of participants asking about trying to find a lymphedema specialist in their area. And I know this is a challenge. I would direct people to the LE&RN website, which has a very good area to help find lymphedema therapists by zip code. And that's a good resource for participants. I'd be happy to help offline. How long after the vaccine do the lymph nodes remain swollen? Well, in our cohort, we found that participants were reporting up to 10 days. They remained swollen. And for the test cohort, the general population cohort, they found that for Moderna, it was up to 10 days, and for Pfizer, it was shorter. Is this also a concern for people with lipedema-induced lymphedema? Well, I think lipedema and lymphedema are two very different things. Typically, lymphedema does not happen with lipedema, and there's more current literature coming out on that. I think that's probably a relatively individualized question. I'd be happy to talk about offline, sorry. How long after the vaccine should one wait to have a mammogram? There has been a lot of work in this area. We know that lymph node swelling is a benign finding on breast imaging for up to 6 weeks after the vaccine. So I know at MGH, as they are doing mammograms, they're asking patients, when did you last receive a booster dose of the vaccine? And if they do see lymph node swelling, the patient will be informed that this is a benign finding on a mammogram, and they will follow up clinically if needed. I think MGH has been instrumental in saying, don't wait to have your breast screening, don't wait to have your mammograms, but you should be asked about the vaccine. You should be asked about the vaccine. And do you have any more information on PET scans and lymph node swelling negating PET scan results, and for how long? I have to be honest, I don't think I'm the best person to answer that question. I would defer to our imaging department for that. See, somebody asking about, hello Maeve, somebody asking about our volume formula again. We can certainly send you that paper. I'll do that offline. Are we collecting data on arm volume associated with those who had lymph node swelling on the breast cancer side? We would very much like to do that. We will need to submit an application to MGH to study that. I would like to do that. But we would, of course, need to submit a study to do that. I think that we need to do that. Have you noticed increased rate of onset of lymphedema in those who received the vaccine that were at increased risk of lymphedema? Very anecdotally, this is not a study that we have done. Anecdotally, I have not seen that at MGH, which I think is encouraging, but we would need more longer term data to look at that. This is a great question. Did you collect data on participants who had tested positive for COVID along with symptoms prior to getting the vaccine? And if so, was this associated with an increased likelihood of axillary node swelling side effect? We have not looked at participants who've tested positive for COVID together with arm volumes or lymph swelling. I think that's a fantastic question though. Have you seen that educating clients on self-care with MLD starting a day after their vaccination help them have more control of edema or lymph node swelling? I have not been routinely telling patients to do MLD. MLD, for those of you who aren't aware, is manual lymph drainage. It's a type of massage that we use in lymphedema management. I have not been educating patients to do MLD after their vaccination. I have heard of a few patients doing this, but I don't have data on that. Message from Cam Ayala. I have heard from several primary and secondary lymphedema patients, not breast cancer, who had the vaccine and have had issues post-vaccine with an increase in their central lymphatics or abdominal area. Can you speak to any literature or studies that are addressing this patient population? I cannot speak to any literature or studies that are addressing this patient population. I hope that's happening. Certainly, if you've heard multiple reports of that, I certainly hope that's happening. Unfortunately, I can't speak to literature in that area. I'm not aware of any. Can you get swelling on the breast area, the cancerous breast? The vaccines were taken on the opposite side. I'm assuming that this participant is asking about swelling on the breast area after vaccination. I've not seen that. I would say if a participant has had a history of breast cancer and has swelling on the breast area that does not resolve after vaccine, certainly after a couple of weeks, I would seek out your oncology team or your medical team to have a look at that and just rule out any issues. With lymph node swelling, I suppose that's possible, but I would certainly have that addressed if it's not resolving. And was there any further follow-up regarding other vaccine-related problems on the part of patients, such as blood clots, since platelet factor 4 is connected with lymphatic diseases? Blood clots have been a problem in general related to these vaccines. So we have not done any further follow-up regarding blood clots in our cohort. We don't have that data based on our survey data. So I'm sure that there may be other research in external facilities, but I'm not aware of that. So I'm sorry, I can't answer that. Okay, and I think I've gone through most of the questions at this point. I'll just give a minute to see if anyone else has any other questions. I may have missed one or two. Let's look. One patient asked a slightly different question, but I can certainly speak to it. Can you speak about radiation therapy impact on lymphedema? I had bilateral mastectomy for triple negative breast cancer, developed lymphedema, and now will be getting radiation. I've received vaccines, 2 doses and a booster prior to surgery and development of lymphedema. So yes, I can speak to radiation therapy impact on lymphedema. We know that breast and chest wall radiation do not increase the risk of lymphedema. It is lymphedema to the lymph nodes that offers a risk of lymphedema. And in fact, the main driving risk factor for lymphedema is the nodal surgery, is the lymph node dissection, and much less is the regional nodal radiation. But regional nodal radiation can increase very slightly the risk of lymphedema, but the main driving factor is axillary lymph node surgery. And our team published this data, George Noem et al. Published this data in JCO about a year ago now. Has anyone reported lymphangitis in people who are vaccinated or COVID positive? I'm not aware of data in that area, I'm sorry. And I think that's all of the questions at this point that I can see. So I think I will sign off at this point. I am very thankful for the opportunity to present, and I thank you so much for your attention.